So I'm going to go over assisting with the activities of daily living. So this is more getting into what the care assistant is actually doing in the nursing home. So I'm talking about a lot of skills and practical things that you need to know and what you should be doing, what you'll actually be practicing every day. So this is for new care assistants to understand their role in looking after residents and what they will be required to do to achieve this. The learning outcomes for new care assistants to be able to demonstrate knowledge of the activities of daily living, and then the nursing cycle, specific nursing interventions, documentation, and how to perform certain tasks to be able to fulfill their role. So the activities of daily living, so this is actually something that we talk about in nursing, and it's what someone has to do every day in their daily lives. So the first one is maintaining a safe environment, communication, breathing, eating and drinking, elimination, washing and dressing, controlling temperature, mobilization, working and playing, expressing sexuality, sleeping, death and dying. So the main role of the care assistant is to assist the service users in achieving these activities of daily living. So something like death and dying, so then a service user will not be in the last final days or hours of their life every time, but it may be something that we're generally thinking about. So maybe something like contributing to the advanced care plan, or something that's come from the advanced care plan that you're assisting with. Expressing sexuality, that could be something as simple as helping them to apply makeup. So those two that you may be a bit dubious about, it's just as simple as that. Very obvious, eating and drinking, your assistants eat and drink, washing and dressing, mobilizing, working and playing is like the activities, like to occupy them, for example. So that is the activities of daily living. So you would need to know that would be across all different work areas. You need to know this. The nursing cycle. So when we have a problem, this is what we apply to try and solve that problem. So the first thing, we always assess. Based on that assessment or risk assessment, we then make a plan, or a care plan maybe. We then implement it and we review, and it goes round in a cycle. So that's why it's called a nursing cycle. So we could apply that to the problem of preventing a pressure sore. So you do your risk assessment up here, so like your Waterloo score. Then based on that and our clinical judgment experience, we'd write a care plan. And then what's in that care plan, we would implement it on every shift. Every registered nurse and care assistant would implement what's in that care plan physically, like turning people, checking the air match, etc. And then we will review it once a month, and as required, if there's a change in that person's conditions, if they just come back from hospital, if there's a significant change in their weight, for example, or they've become less mobile. So that's applying it to the prevention of pressure sores, but you'd apply this to any problem. So every day we need to inspect the service user's oral cavity and to provide oral hygiene. So you should have a look in the mouth. We're not expecting you to know what every single problem is, but we do want you to understand what is normal for that resident and what is abnormal. So you would report what is abnormal. So for example, this person's tongue has a thrush, so that's a fungal infection. So you report that to the registered nurse at handover. So that would need to be treated. So you have a look in their mouth first and see if there's anything abnormal. If they if they have teeth, then assist them to brush their teeth with toothpaste and their toothbrush. Always get them to do as much for themselves as possible. If they have dentures, we can clean the dentures with a toothbrush, and I've been told not to use toothpaste because that can damage the dentures. Either just water, or I've been told you can use like washing up liquid on the toothbrush to clean them. They can be soaked overnight in like a Sterident, for example, and then cleaned before you put them in. Clean them when you take them out at the end of the day as well. Don't leave them with them in their mouth when they're sleeping, because it could be a choking hazard. And then if they haven't got dentures, or they have got dentures, but they still got their oral cavity, needs to be inspected and cleansed. So if they had no teeth, we could use like an oral hygiene tray. These sponges, these swabs, you need to check. You'd have gloves on. You'd have to check that this does not come off, this foam part, and blocks their airway. Okay, you can use a spatula in there the tongue depressor to inspect the mouth, and then this can just be swabbed around. You can put like mouthwash in here, like dilute it to help cleanse the mouth. Always use like something like Fixodent to secure the dentures into the mouth, and it's very important this happens every day. Catheter care. So some residents have a catheter that drains urine from their bladder. It needs to be handled carefully to try and prevent infections, urinary tract infections. It's almost inevitable, and it is inevitable, if someone has a catheter put in, they will have at some point will have a urinary tract infection. We need to try and decrease the chances of that happening. So the catheter bag has to be below the bladder. So you can see in this picture, it is below the bladder. So the person is lying on the bed here, and the urine is draining downwards from their bladder. So taking any bacteria away from their bladder. If you held this up, then the urine could go back, and it takes any bacteria in this urine bag in the pipe back into the bladder and causing an infection. So always below the bladder. If it's a bag that needs to be emptied, then you will empty it into a receptacle without it touching the end of the like nozzle. Okay. Ideally, do clean it with alcohol wipe as well before you emptied it. You make sure it doesn't touch the floor as well, because any bacteria could travel up into the bag and swim or crawl its way up. Okay. Always have gloves and apron on when you handle the catheter bag. The nurse will deal with changing the catheter and any troubleshooting with it. So your role will be to monitor it. You have to monitor how much is coming out, how much they're drinking, and how much is coming out. So we know there's a fluid balance. So we're checking the function of the kidneys, making sure the bladders they're not urinary retention, or there's a blockage in the catheter. But the main thing is that you need to when you're handling it, you need to do it in such a manner that you don't increase their chances of developing a urinary tract infection. Some residents have had surgery on their bowel. Possibly if they had bowel cancer, it may have been removed surgically, and they've had to have a stoma created. So they'll have a hole in their abdomen with the intestine protruding, and they'll pass stool via that stoma, and that needs to be, it can be in several places over the abdomen. It needs to be covered with a stoma bag. There's different types of stoma bag. It has to be cut down. This particular one has to be cut down to the right size. There's different types. There's ones that stick on and you take them off every time. There's other ones that stay stuck on and you attach it to that part. If someone has a stoma, it will be in their elimination care plan, further details on their specifics. You obviously need to wear gloves and apron if you're changing that. You need to be careful when you're cleansing it, not to damage the stoma. It can, if it's been cleansed regularly, it might become like damaged and bleed, etc. So you need to be careful. Follow what's in the care plan. Report any problems to the nurse. It should be emptied every 2 to 3 hours, and it depending on the type, they may still pass stool via their anus. So if they never have done before, obviously tell the nurse, but it could just be the type of surgical technique that they've had. You will practically be showed how to do this by other care assistants as well. Incontinence means not having full control over when you pass urine or stool, and continence is the opposite to that. So we're going to try and promote continence. So we try and promote a service user being able to have control over when they pass urine and stool. Okay, there's different types of urinary and fecal incontinence. Urinary incontinence, you can have stress incontinence, when urine leaks out at times and the bladder is under pressure. For example, when someone coughs or laughs. You can also have urge incontinence, when urine leaks as people feel a sudden intense urge to pass urine or soon afterwards. There's an increased risk of falls with urge incontinence, as someone may try and desperately get to the toilet. People with incontinence may reduce the amount they drink, believing this is going to increase their incontinence, but is actually the opposite. They should drink more to manage it. The bowel incontinence, it can also be urge or passive. So we still need to ask people if they want the toilets. They need to have the call bell in their reach to be asked for the commode or the bedpan if they're in bed. We need to predict when they may go to need a toilet, such as after lunch. They're very likely to need to have the toilet to pass stool. The pads, the incontinent products, they are for safety. I mean, some service users just will have such advanced dementia and they're bedbound. There's just no way that we can know when they need a toilet, so we have to basically rely on the incontinence product to sort of protect their skin and the bed, etc., and to give them some dignity. It needs to be checked at least every 4 hours. There'll be more details in their elimination care plan, and you'll be taught on the floor by other care assistants. And I have a video of practically how to provide personal care to someone. But just something, like an overview. You should never ever tell a resident to open their bowel or pass urine into their pad if they've asked for the toilet. If they've asked for the toilet, then they go to the toilet. Okay. Documentation. So all care must be documented. It should be documented as soon as possible after care has been provided. If there's any refusals, you need to document it and tell the registered nurse. You need to hand everything over to the registered nurse at handover time. If something, you're going to learn what's important, what you need to immediately tell the registered nurse, and then you're going to learn what can wait till the handover time. So we use the Nourish system now, so it's all on the computer rather than on paper. You'll have a handset. You'll be given your login details, and you'll learn how to enter all the information onto that device. So everything they eat, drink, when you empty the catheter bag, how much urine is in the catheter bag, the behaviour charts, everything, daily notes, everything is on that Nourish. The only thing that is possibly not on the Nourish is a 72-hour behaviour chart. That will be on paper still. Handovers. So handover is the cornerstone of communication. Very important for communication. So it occurs formally at 7:30 in the morning, 11:30, sometimes at 2 o'clock if there's staff starting at 2 o'clock, and at 7:30 for night every day. So during this time there should be staff on the floor, so to cover the call bells, to observe residents, etc. It's confidential, so there should be no one in there or able to hear it who should not be hearing it. There should be no service users in that handover. Even if you believe they don't have capacity, they should not be listening to confidential information. It's not a break. One person talks at a time to hand information over. We do need to be consider the timing of it. So it does have to have some pace to it, but we do need to make sure that all staff hear all of the information. So if information is not passed over, it could cause a cascading effect, and we could have a very significant problem, for example. So it's very important we have a very good handover. Types of diet. There's different types of diet. I say normal diet, then we have diabetic diet. So basically there is no diabetic diet. A diabetic diet is a normal diet. We should all be eating a diet that is low in refined sugars and follows that Eat Well plate, which I've mentioned in a different presentation. We also have different consistency diets. So I'll talk about the IDDSI levels in a minute, but you have a soft or pureed, for example. That's about consistency. The types, so yeah, we may have like a normal diet, but you can also have gluten-free for someone with celiac disease. You might have a low potassium diet for someone who's got kidney problems. You may have a low sodium diet, for example. They're quite specialist when we have these, quite rare we use these diets, but most people can have a normal diet and then it's either a soft pureed or normal consistency. The resident may have supplements, nutritional supplements, as they're losing weight, such as well, it's quite rare to see FortiSip now, but FoodLink is very popular with the dietitians and GPs, and they may have thickened fluids, which I'll talk about next. So if there's a suspicion that a resident has a weak swallow, either due to their condition or due to observation of let's say coughing during eating, they may be referred to a speech and language therapist. Now this is a healthcare professional who will come into the nursing home and assess the resident's swallow, and then they recommend an appropriate diet. So before they come in, they usually ask for like a 7-day swallowing diary, where we maintain like details on what they ate and then how they ate it, if there was coughing, etc. Typically, we'll see speech and language therapists will see residents with stroke, severe dementia, brain injury, a few other conditions, Parkinson's disease, that can lead to weakened swallowing. Now, the reason this is so serious is because they could have they could choke on the inappropriate consistency diet. But the other thing that can happen is like small bits of food or drink can go down into the lungs and lead to chest infections. So it is very serious. So we do need to give the resident the right consistency diet. So they will advise us what to give someone. So if they say thickened fluids, for example, they'll say which level, which IDDSI level 1 to 4 we may use. We used to have this stage 1, 2, 3, but it's now moved to this IDDSI level, and this should be on the handover sheet. It should be in the care plan, in the nutrition care plan, on the choking and aspiration risk assessment as well, which is on the Nourish system. You will be told at handover. Always ask if you're not sure. So look on the side of the thickener tin. So for 200 milliliters, if it's level 1, you put 1 scoop. Level 2 it's 2 scoops, etc., etc. So level 4 would be extremely thick. That would, if you put, you'd have to use a tablespoon to give it to them, or a teaspoon. And if you went in and scooped it out and you turned it over, it wouldn't fall off the spoon, for example. It'd be so thick. Now that thickener is to slow the movement of the fluid down in their mouth, so their weakened swallow can manage it safely. They have to be sat upright. You need to give appropriate time between mouthfuls. You need to observe them. The diet will also be an IDDSI level. So puree or soft, etc. There is detailed guidance in the nutrition care plan, and all fluids would have to be thickened. Obviously, water wouldn't be nice. It would be like wallpaper paste if it just had the thickener. So it should be flavored. Something that's milk based like Fortisip is difficult to thicken, so they should be prescribed an already thickened alternative, such as like Forticream rather than Fortisip, for example. If a resident had a very weak swallow and the speech and language therapist did not believe it was safe to advise any consistency diet, they may request the GP refers them for a PEG insertion, or they may come in with this already. Sometimes there's residents who are very high risk of choking or aspiration, but it wouldn't be appropriate to put a PEG tube into their stomach, but we might have something called risk feeding occur, where we're going to still feed them, but it's very high risk. But it's been advised by the speech and language therapist. But if someone was appropriate to have this done, this would be a surgical technique where a tube is put through into someone's stomach, and they're fed through a pump, and they have to be upright at 45 degrees when this pump is on. Only the registered nurses will manage the pump, etc. So if there's any problem, you have to put them flat for any reason. The nurse has to come and turn off the pump. Assume they are nil by mouth unless you are told otherwise. I have had some patients before who have had a PEG feed and have eaten as well, but you need to check in the care plan, check with the nursing staff what the situation is, but just assume they are nil by mouth otherwise. If they are nil by mouth, they're going to need regular 4-hourly oral care, because their mouth is going to become unhealthy if they're not eating or drinking anything. And also consider their lunchtime, where if they're up out of bed, like where they are, they could become distressed if other people are eating and drinking around them. Assisting with eating and drinking. So there's a lot there, but basically you need to create the right environment to encourage someone to eat. The way you talk to them, the way you talk about the food, you need to like have a situation created where they want to eat. You need to consider the environment, like what they're seeing or what they're smelling. You don't want them to be smelling, let's say the used commode, that should be away beforehand. The way you lay their table, this is all very important in increasing their appetite. They need to be sat upright. They need to have the right consistency diet. Maybe it's better to feed them with a spoon rather than a fork, so you don't damage their lips. Maybe they have a bib on. Offer them whether they want the bib or not. Always check the care plan for any particulars. It just educates you generally about how to do this for people. And you need to make it a pleasurable experience. And then importantly afterwards, you need to document how much they've eaten and how much they've drunk. I have done a separate training video on how to provide personal care to someone. Every day someone has a bed bath or blanket bath. This is just what they should have. If they ask for a bath every day or a shower every day, then they should have a shower or bath every day. The main reason we do the bed bath or blanket bath is to achieve personal hygiene, but it also allows the whole body to be visualized for any problems, etc., like pressure sore development, allergic rashes, bruises, etc. So anything abnormal you see in their body, you're going to report it as appropriate to the nurse, either immediately if you think it's serious, or you wait till a handover, and it's only experience you're going to learn which one to do for what problems. But it's very important to assess their body every day. Further to this, it also allows you to assess their mental state, because you should be talking to them during this, and you should be able to pick up any problems or concerns that the resident may have, and you'll report this back. It's also the opportunity for active or passive exercises to occur to prevent the development of contractures, and you should always encourage the resident to do as much for themselves as possible, because this will increase their self-esteem, their mental state, and it will keep them physically more active for longer. It's very important to encourage them to do as much for themselves as possible. Bathing and showering. So if they ask for a bath or a shower, they can either use the like the Parker bath here, which is the same as like how you get in and out of the bed. So when I've done that in manual handling, it's the same. Or they have the shower. We do have a reclining shower chair if they haven't got good sitting balance. You always check the water temperature beforehand, both with your hand to make sure it's not too hot, and then with the thermometer. So you need to check that the water temperature is between 38 and 42 degrees Celsius, and we need to record that in the Nourish system. Okay. So I have this in a separate video. That's it.